Well, I'd like to thank the AIN and the editorial staff of the Neurology Journal for the opportunity to take part in this very exciting new video journal club. Our conversation today is going to focus on a paper in, I believe, the May 24th issue of the Green Journal. So quite literally hot off the press. I don't even think it's actually off the press yet. I think it still has an electronic citation. The paper is called Progression to Dementia, or Reversion to Normal Cognition in Mild Cognitive Impairment as a Function of Late-Onset Neuropsychiatric Symptoms. And the paper explores whether the construct of mild behavioral impairment, a kind of newish idea that describes late life persistent neuropsychiatric symptoms, can improve the prognostic precision of mild cognitive impairment. My name is Dr. Amy Sanders, and I am an associate professor of neurology at the University of Connecticut School of Medicine and the medical director of the Memory Care Center at the Ayer Neuroscience Institute at Hartford Healthcare, right smack dab in the middle of Connecticut. And with me today is my colleague, Dr. Izabella Shuvayev, who I will let introduce herself.
Hi, everyone. I'm Izabella Shuvayev, and I'm a geriatric psychiatrist here at the Ayer Neuroscience's Memory Care Center.
So it's interesting, I think, that we have on camera today a neurologist and a psychiatrist. So many times these days, those are circles that do not overlap in the Venn diagram, but we overlap almost entirely here at the Memory Care Center. And this is a paper that focuses in large part on neuropsychiatric symptoms and their implications for what is, for progression to dementia, a neurological and psychiatric condition. And the paper is published in a neurological journal, but its main authors are in fact psychiatrists. So I think that, you know, we're a good team to be able to discuss this paper, or at least I sure hope so. So I want to begin with some reviewing of terminology. I recognize that the field of cognitive neurology, maybe most parts of neurology these days, has a lot of acronyms in it. And so we want to take some time here at the beginning to define some terms so that we don't lose anybody along the way. And Izabella, I think you're going to start us off, right?
Yes. So because the hypothesis of the study is the co-occurrence of mild cognitive impairment and mild behavioral impairment and how they represent a heightened risk for disease progression to dementia and lower likelihood of reversion to normal cognition, it is important to define these two terms. So I'll start with mild cognitive impairment. Mild cognitive impairment, the term was actually coined in the 1990s by Ron Peterson and his colleagues. And it is a concept of being a stage in between normal cognitive aging and pathological dementia type aging. So that intermediary stage of mild cognitive impairment. Not every mild cognitive impairment progresses to dementia, so that's important to remember. It sometimes continues to be stable or reverts back to normal cognition. But as a stage, it is marked by symptoms of memory loss and or other cognitive cognitive or thinking problems that are expected to be greater than normal persons that are greater than what is expected for a person's age and education. However, they are not severe enough to interfere with personal independence, so independence in activities of daily living. So this stage shows definite change in cognitive function from previous level of functioning. However, it precludes the dementia level of impairment.
Right, now, and that can be a very tricky concept to understand, is just how much functional impairment is too much to qualify for mild cognitive impairment. And the way that I heard it described best was someone who said that people are having struggles perhaps to do things that once they were able to do without a lot of struggle, but they're still able to do whatever the thing is. If it's to write a check or plan a dinner party or drive a car or whatever it is. So it's not yet being dependent on someone else. They're still able to complete the function, but it becomes more difficult. And I can't resist the opportunity of this presentation to drive home also the point that there are formal diagnostic criteria for mild cognitive impairment, and they do not include making the diagnosis on the basis of a screening cognitive tool like a Montreal cognitive assessment or a mini mental state exam or the St. Louis University mental status exam. Those are helpful instruments, to be sure, but they do not define the state of mild cognitive impairment. In fact, one of the original criteria was that normal or that general cognition remained normal. So that's an important take-home point about what is mild cognitive impairment and what mild cognitive impairment is not. So I stepped on your presentation there a little bit.
No problem. So the diagnosis of MCI does require concern about a change in cognition relative to previous level of functioning and impairment in one or more cognitive function. However, preserved ability to function independently in life, although some complex tasks can be more difficult, and no dementia. So the mild behavioral impairment is the neuropsychiatric symptoms that are characterized by an onset late in life. And these symptoms should represent a distinct change from a long-standing pattern of person's behavior or personality. And these neuropsychiatric symptoms are not best or better accounted for by a psychiatric disorder, and they must persist for over 6 months in duration to be defined as mild behavioral impairment. I think that Amy, Dr. Sanders, you'll be talking about the NPIQ and
yes. So this study was done taking advantage of the very, very large data set represented by the uniform data set of the National Alzheimer's Coordinating Center. So that is a group of Alzheimer's disease research centers funded by the National Institute on Aging. And they started collecting their longitudinal data more or less in the format that it's collected now. And full disclosure, we do not work at an ADRC, and we don't contribute data to the NAC or to the UDS. So if I make an error, please forgive me. But the longitudinal data, as is it's collected today, that data collection began more or less around 2005. Participants come for an annual evaluation, and they can be individuals with normal cognition, they can be individuals who have received a diagnosis of MCI, they can be individuals who have received a diagnosis of dementia. If individuals become too impaired to participate in the usual annual data collection, but they have given consent for eventual brain autopsy, they are continued to be followed, even though they can no longer really contribute data to the overall data set. And the data set includes quite a lot. This is a very extensive collection of data for tens of thousands of people. So in addition to neuropsychological data, there are imaging data, so MRI and amyloid PET, and also now CSF biomarkers. The neuropsychological data includes a blind MoCA. So this is I don't know if it always included a blind MoCA, but I'm sure that there was some pivoting that happened in the last couple of years due to the COVID pandemic, where perhaps people were not as able as they once had been to come in for an in-person assessment. So some of this was converted to telephone or telemedicine formats. So they're using the blind MoCA. There's an episodic list learning memory test task that is where they look at both immediate recall and delayed recall. Same thing for a story recall, so both immediate and delayed. Working memory is assessed using a digit span format. Verbal fluency is assessed both in terms of semantic fluency, so by category, how many animals can you name in a minute, and also by phoneme. So what's the first letter of the word, and how many words beginning with, say, F can an individual name? And then also there is a naming exercise. So that is more or less the data set that the authors of this paper had at their fingertips. And they used primarily, so the one thing that is not included in the NAC-UDS is anything about mild behavioral impairment. This is a relatively new idea. And if you do one of those little PubMed searches where you get the little graph off to the left, where you can see the increase, the linear or the not linear increase in the number of publications in any given year, publications about mild behavioral impairment are still, for the most part, numbering in the hundreds, not the tens of thousands. I didn't compare how many there are for mild cognitive impairment, but I bet my lunch that there are tens of thousands for that. So mild behavioral impairment is a much newer idea. And so the authors of this paper had this rich data set, and they were asking a question about, does mild behavioral impairment increase the precision about mild cognitive impairment, about whether somebody's going to progress to dementia? But they don't have data from the uniform data set in order to answer their question. So they had to figure out a sort of a workaround. And they wound up using something called the NPIQ, the Neuropsychiatric Inventory. And this is a version that is can be completed individually by a care partner or the informant for the patient. It assesses 12 different categories. The number 12 is important to remember here. And the categories that it assesses are whether there is depression, whether there are hallucinations, whether there's agitation, whether there is anxiety, is there elation, is there apathy, is there disinhibition, is there irritability, is there motor disturbance, are there aberrant nocturnal behaviors, and are there changes in appetite that seem to be pathological? So not only does the informant indicate the presence or absence of each of these 12 subtypes of neuropsychiatric impairment, they're also asked to grade the severity, mild, moderate, severe, and to grade their own distress on a 6-point scale going from 0, no distress whatsoever, all the way up to 5, which is extremely distressful. So the uniform data set does include collection of the NPIQ data. So that was a starting point for the authors. And they then sort of transformed in using a method that has been used previously and has been shown to be valid and reliable. They used the NPIQ data and transformed it according to the Alzheimer's Association ISTART. And look at me here, I can't remember exactly what the acronym ISTART stands for. It's one of my worst acronyms.
It's I can help you out there.
Okay,
it's the
thank you.
International Society to Advance Alzheimer's Research and Treatment.
There you go. I've been trying to remember it for years and I've given up. So anyway, so the ISTART in conjunction with the Alzheimer's Association has come up with a set of sort of defining domains for mild behavioral impairment. And the authors of this paper sort of back transformed the NPIQ into the ISTART domains. And that was then their data point, their metric that they were able to use as the main variable for their studies, for their analyses. So,
and these were so the decreased motivation was taken from the apathy and indifference in the NPIQ, et cetera. The affective dysregulation was similar to depression, dysphoria, and anxiety scale, and that's how they got the results.
Right, and they managed to capture somewhere between 80 and 85% of the data that the NPIQ gets. So there are 12 aspects to the NPIQ, and the ISTART MBI includes
10 of them.
10 of them, yes, thank you.
And because they didn't include the nighttime behaviors and appetite.
Right.
Mm-hmm. Should we talk about the how the exclusion criteria or the inclusion criteria for participation occurred?
Right. How did they whittle down this this data set from its starting point of over 43,000 individuals to have a a data set that would be big enough for them to work with, but not so big that it would be unwieldy.
Exactly.
It's kind of interesting how the exclusions went.
Right. So all the participants were over 60 years of age. And we started off with, as you mentioned, about 43,000 participants. And they excluded about 13,000 because of psychiatric and developmental illnesses. So that included PTSD, bipolar, schizophrenia, and Down syndrome, Huntington's disease. After excluding these psychiatric and developmental illnesses, they also excluded the data that did not have a full NPI-Q domains. So if there was any missing data from the NPI-Q, they excluded that. After excluding that, they also had to exclude all the data that did not include beyond the first visit. So if patients only came in once, they excluded that as well. So as long as they had 2 UDS visits, the participants were included, so that we ended up with 18,000 participants.
Right. To give you some sense of the scope of the exclusions here, over 13,000 people were excluded on the basis of having pre-existing psychiatric conditions. And over 10,000 people were excluded because they only completed 1 UDS visit and did not return for the second UDS visit. So those are some fairly substantial numbers who got excluded there at the beginning.
Exactly.
I mean, rightfully excluded, but perhaps with implications.
Right. And then the 3 categories that remained were participants who had no neuropsychiatric symptoms at both first or second visits, and participants who had neuropsychiatric symptoms at both visits, which became the MBI positive group. And then that intermediate group of participants who were sent to the secondary analysis. And these were patients who had neuropsychiatric symptoms at either the first only visit or the second only visit.
Right, so everybody had MCI. And then what was different among the various groups was the extent to which they had neuropsychiatric symptoms.
Exactly.
Yeah, so I mean, at this point, it's pretty interesting analysis that is shaping up here. So what did they find?
Well, they found that neuropsychiatric symptoms, the presence of neuropsychiatric symptoms, especially if it was MBI, that led to progression to dementia at a higher rate and less likelihood of conversion back to the normal cognitive state.
Right, and is that important? I mean, who cares? Do we care?
We care very much because we need the prognostication. We always want to know the rate of conversion from MCI to either dementia, and is there a chance to, and what can happen if we do convert back to the normal cognitive state? I mean, that's what patients want to know, right?
Absolutely. I mean, I can't tell you how many times I would say, if I'm making a diagnosis of mild cognitive impairment, the question is almost always raised about, well, am I going to progress? Hard to say for sure, one way or the other. I mean, my usual answer to that question is perhaps a little bit glib, but I say my crystal ball is cloudy. I can't see. I can't tell you whether or not you're going to progress. And then I cite some epidemiologic data about the likelihood of progression, but that's big data. And so it doesn't necessarily apply to the man or woman who is sitting across the table from me in my office. And people also, I feel that it's incumbent upon me to say, well, and sometimes people actually sort of back transition to a state of normal cognition. And then people get really excited. Well, what makes that more likely? And then I feel like an idiot because I have to say, well, we don't really have a good handle on that yet. So, this paper, this analysis moves the ball a little bit. Doesn't necessarily get it between the goalposts, to use, sorry, a laborious football metaphor, but it does, I think, move the ball a bit.
It does. This is the first paper to show that the presence of MBI is actually less with the MCI, means that the progression to normal cognitive state is less likely. There have been papers that show the association between MCI and MBI being more detrimental or more likely, showing more likelihood, the higher likelihood to progression to dementia. But there haven't been prior papers, from what I understand, describing the backtrack, the reversal of MCI to normal cognition.
So in the grand scheme of things, this paper maybe is the leading edge of a possible paradigm shift. Up to now, we have defined cognitive diagnoses, be they normal cognition, MCI, any of the forms of dementia, pretty much exclusively, not entirely exclusively, but especially in the clinical domain as opposed to in the research domain. We're still largely working on the basis of what's their cognition and what is their function in terms of completion of their instrumental activities of daily living and their more basic personal care activities of daily living. And this paper convinced me that we really need to add another dimension. And we need not only to think of cognition and function, but also about neuropsychiatric symptoms. And to me, that's a big deal. And I think it feels a little bit more right, a little bit more describes the population who I see in my clinic every day, because it's not all just about cognition and function. The neuropsychiatric symptoms are very, very important. And if you think back, and I literally just had this thought this moment, so if it comes out a little bit unformulated, I beg your forgiveness. But the first patient ever in the literature who was described as having Alzheimer's disease was absolutely nothing like we now think of Alzheimer's disease. And she had florid neuropsychiatric symptoms. So it was really there at the beginning. And we're now in the latter days sort of circling back and now sort of coloring in the picture a little bit more completely.
And of course, when patients tell you, or the caregivers mostly, the most distressing thing are, sure, forgetfulness is a big part of it, right? But dealing with neurobehavioral symptoms is much more challenging for caregivers and families.
Absolutely, yeah, no question about that. All right, so that's kind of why this paper is important. What are some of the limitations that it had? And some of these, given how good this paper is, some of these are a little bit surprising, I think.
So one of the limitations mentioned is that the NPI-Q, while used here for participants who did not have dementia, right? All the participants had mild cognitive impairment. The NPI-Q was developed for dementia specifically and not MCI.
Right, and this is something actually that the authors do acknowledge, and they suggest that a similar analysis, although it can't be done in the NAC-UDS for obvious reasons, the NPI-Q is there, but there are some, a group of authors has come up with something called the MBI checklist, which was specifically designed to apply to a pre-dementia population. So doing a similar kind of analysis, and you probably could get similar numbers of individuals, at the end of the sort of cascading exclusions, they wound up with 300 or 400 people in each of their buckets. And so that's an achievable number of participants outside of an enormous and multi-year project like the NAC-UDS. So doing this kind of analysis on a population with MCI and MBI, but using a tool that was developed for that population is really probably the next step.
I was also curious, I think it would be interesting to see more specific description of MCI subtypes as we know them. You know, the paper does not differentiate between, let's say, an amnestic MCI versus a non-amnestic MCI versus a multi-domain. And that could be interesting because as we know, that amnestic MCI is more likely to progress to dementia versus other types.
Right, and non-amnestic MCI is I mean, MCI in general is a heterogeneous state, and non-amnestic MCI even more heterogeneous. So and you know, do the non-amnestic people have a greater chance of back transitioning to normal cognition? Maybe they do. And what difference then does concomitant MBI, what role does that play in sort of ascertaining their chances to move in a good direction as opposed to an unhappy direction?
Sure.
So one thing also that I found interesting was that, and this is really just sort of an aside, but they collected or had access to ApoE status. And this is one of the few papers that I have ever seen where ApoE status didn't matter. You know, the final groups, there was no statistical difference among the three groups based on the presence or absence of an epsilon E4, of an epsilon 4 allele. Interesting. I don't know exactly what to make of that because it's quite unusual, but perhaps worth some additional digging. And then one thing that really sort of really caught my eye was the amount of exclusions and the amount of missing data. So those 10,000 plus individuals who were excluded because they only had a single visit, that's 25% of, practically 25% of the entire NAC data set. And does it matter? I mean, is that data missing randomly, where the missing group is not any different than the group who stayed in? Or is there an informative dimension to that missingness? And it's way, way above my head to perform such a statistical analysis. And I know that there are some very sophisticated data imputation techniques that can be used to do that. But that, I think, is something that could be done on the very data set that was used in this paper. And I think would be very much worth doing. I think that would be pretty interesting.
That's a great point.
So, so what are we left with?
I guess recommendations and future directions, right? I think the importance of recognizing and bringing it to the clinical setting, the ability for clinicians to gain that understanding of the presence of neuropsychiatric symptoms concurrently with MCI or even without MCI, right? I think we talked about before that there is no group which is not an MCI, the presence of neurobehavioral symptoms without a cognitive component, and whether there is any possibility for progression to depression, dementia with that. But I guess in the clinical setting, the most important thing is to start making it as a routine way of checking, just like we check functionality, right? Ability to complete your instrumental activities of daily living and any forgetfulness or any other memory components and screenings that we're doing in clinical settings. Paying attention to the neuropsychiatric symptoms and behavioral changes, personality changes is definitely a recommendation.
Yeah, because you just don't see the whole picture otherwise. So it really is, I think, kind of a paradigm shift, and an important one, and one that was fun to talk about.
Agreed.